So I know we were asked to talk about where to, but you sort of need to understand where from to explain why we are where we are now and heading in that direction. So if you could give us the next slide. The background to the mortality reporting that Vahi does starts a long time before Vahi's own inception. I really enjoyed going back in time in our first presentation and looking at VASM and its inception. From the point of view of formal mortality reporting, even in the early noughties, there were some initial Victorian work on developing patient safety indicators for the hospital system at large, and there were in other jurisdictions too. In 2009, Australian health ministers actually made a formal recognition that hospitals in Australia should have access to benchmarked quality and safety data, including mortality indicators, and they started the process of commissioning that work. So our own work contributed to a lot of the original suite of indicators that were defined, and there was some important work from Flinders University that looked at what was then the cutting edge of mortality reporting, how to do an Australian hospital standardised mortality ratio. That work resulted in a lovely acronym, Core Hospital-Based Outcome Indicators. Everyone calls them CHBOIs. I think they were implemented in Victoria pretty quickly in early in the decade we've just come out of. They comprised a hospital standardised mortality ratio, a death in low mortality diagnosis related groups, DRGs measure, which was intended to provide an alert when you were seeing more deaths than ought to be occurring to low risk patients, and in-hospital mortality measures for just 4 specific conditions: AMI, stroke, fractured NOF, of particular interest here, and pneumonia. It was a really important step, I think, when we first implemented those in Victoria, well before the inception of Vahi. But there were also real limits to what we were able to present. And perhaps one of the most important limitations that was reflected over the years in many different ways was that because the modelling and the definition was based on a national compromise and the evidence base was national data, it was often very hard to explain why Victorian hospitals were having the results they did. We know that Victorian hospitals report all sorts of things a little bit differently from the rest of the country. We know we fund and report palliative care in particular quite differently. And so sometimes it could be quite difficult to have a meaningful engagement with health services around what was really going on. It was a great start, but it really wasn't enough. And everyone's already alluded to targeting zero. It made it very clear just how much it really wasn't enough. But that cluster of deaths at Bacchus Marsh did lead to really important reforms. We've already touched on the establishment of Safer Care Victoria and Vahi and what their mandates were. But also there were changes to how we actually expected the DHHS to work with health services to monitor their performance around quality and safety. In particular, it became really explicitly made clear through the new system that there was no trade-off with quality and safety with other sorts of performance. It didn't matter what your finances were, it didn't matter how you were doing in other KPIs. Quality and safety stands alone and is monitored from the perspective that we are targeting zero. We're trying to make every patient safe and care as high quality as it could be. This meant, of course, that we had to start developing a whole lot of new indicators and reports to support that mission. Next slide, please. So as Vahi was first started, and as I think was mentioned at the start, I'm a fairly recent addition to Vahi, but I've spent some time at Safer Care Victoria before this. The first step was actually to look at what we already had and make it better and more suited for the present environment. So the first measure to get a serious review was AMI mortality measure. We've now developed a new one that looks at 30-day mortality in all settings, not just inpatient settings. So as length of stay decreases for all sorts of treatments, in fact, we'll be able to see what happens outside the hospital walls as well as within post event and post surgery for many patients. We've also refined the death in low mortality DRG measure to get a more Victorian specific and clinically informed understanding of where we might be looking at those low risk patients. We've also promoted that to being reported in the board safety and quality report, to sort of thinking about it in terms of clinical governance rather, I think, than that sort of day-to-day monitoring given the lag in the data. Importantly, even within our standard products like Prism and Monitor, we've enhanced the visualizations we provide, and that too came through recommendations from both health service executives and senior clinicians, mediated through a conversation with Safer Care Victoria, that really what was being presented in the performance reporting previously around quality and safety just didn't give you any idea of what was going on. You could tell whether you were an outlier or not. You couldn't see if that was new, if you were trending well, if you were improving, if you were deteriorating, if you were an inlier but at risk of becoming an outlier. None of that was visible. So working with Safer Care Victoria, we have now introduced some changes in how even in those standard products, those standard indicators are presented, that provides something that is a bit more actionable than what was previously there, and that at least now also makes comparisons to the local peers, to a statewide average and peer grouped comparisons. In the unplanned readmission space, perhaps less interesting here, but a really important part of the national quality conversation, we also updated all of our readmission measures in the previous year to an any hospital methodology. And indeed, as the way people use hospital services change, it becomes even more important to see that a person who might have had their original treatment at one site actually perhaps presents at a completely different ED when there is a problem or a complication. So that was a really important piece of work, just to update those existing measures, again, to make them more relevant to how people actually use services and what the issues might actually be. Once again, we implemented enhanced visualizations, and perhaps even more important, in the couple of years before this year, Vahis put a lot of effort into building relationships with the sector and with clinicians in particular. Key bodies I guess that we did that through is the Clinical Measurement and Reporting Committee, which brings together clinicians, health service people, departmental people. Safer Care Victoria chairs it, and we use it as one of our key testing grounds, but also advisory groups. One of the great ways it advises us is it often tells us who else we should be consulting as we do this work. And Professor Waters is a member. The Mortality Expert Advisory Group has also been a really important group composed of other jurisdictions representatives, so that we can learn from them, senior clinicians and hospital executives here, and again government representatives, to make sure that we are staying aligned with the needs of the department as well. And last, but actually the most important, a relationship with Safer Care Victoria. Safer Care Victoria's mandate, as was discussed in the first presentation, is very much to be out there working with health services, working with clinicians. Having come from Safer Care Victoria into Vahis, I was in a minority. I'm not myself clinically trained. Most of the people they're from the sector and working with the sector. And that partnership for Vahis is a really key one. We've been growing it. We want to grow it more. And I think we've achieved some really good things together already. There's more on the journey to come. So next slide. So 2020, unprecedented is usually the polite phrase that's used to describe it. And it really did provide some unprecedented opportunities for innovation, as I'm sure everybody has discovered this year. But from Vahis' point of view, and in terms of reflecting back to the hospital sector, the information it needs to be confident of the quality and safety of the services it provides, I think it's really important first to call out that we actually stayed well on track with most of our business as usual as regards meeting that mission. We even managed to do a bit of new development. So we did maintain all the routine quality and safety reporting we do for hospitals. That's the monthly monitor and PRISM performance focused products, but it's also the ones Mary spoke to you about earlier. So things like the board report, the private hospitals report, we kept them going. We didn't do some of the new development of measures and presentations for them that we originally envisaged, but we made sure that the information got out there. And we did do some development. So as Paul has already alluded to, we did add indicators from clinical quality registries to the board safety and quality report. I really feel personally that that's one of the big breakthroughs Targeting Zero always envisaged, that we would be using clinical quality registry data to actually really meaningfully connect with the clinical governance processes within health services. So I think this is actually one of our biggest steps forward this year. 4 of those indicators are mortality related. And I guess we've also done some ongoing work that we had already started consulting on. We were advised that the National Stroke Mortality Indicator really is not sensitive enough to be actionable. So with substantial clinical advice from our Clinical Measurement Committee, but also from the Stroke Clinical Network at STV, we've put a lot of work into creating new stroke mortality indicators. And actually risk adjusting it in a way that's going to use linked data to get as sensitive as possible in adjusting for different types of patients, but also I guess that's going to really be communicable and translatable into action for clinicians on the ward. We've also put a fair bit of work into looking at what comes next with the HSMR. So an initial paper's been delivered, really exploring the limitations that have been well reported in the literature and well observed in our own experience over the last 10 years. It's a well-intentioned indicator, but it's so high level, it's rarely easily interpretable and it's rarely easily actionable. So we've explored what the limitations are and what we might need to look at in the next tranche of work there. We have also put a fair bit of work into working early in the year before the pandemic with boards around how to use our reports. So not just getting the information out there, but trying to make sure that we're actually part of an ongoing conversation and educative process around how to get the best value out of our products. And the most recent one of our managers has become a YouTube star. His own parents found him by accident. You can go see the little videos he made for yourself on the web if you want to, the links there. Finally, before we move on, the other thing that's really major actually is we've produced the first detailed report on hospital-acquired complications in Victorian public health services. We've presented really detailed time series visualisations, funnel plots, and a whole lot of contextual information about each of the reportable formally defined hospital-acquired complications, again, defined through a national process by the Australian Commission of Safety and Quality in Healthcare. And we've presented for every health service where it's large enough to be meaningful and every indicator where it's actually possible to use a risk adjustment model. We've presented risk adjusted rates to make the comparisons as fair as possible. Perhaps of most interest to this group would be that the formally defined HAC4 is for surgical complications requiring unplanned return to theatre. And perhaps tying in with what Paula was just talking about, there's also a medications complications HAC formally defined. Now, this is the first time that we've put such comprehensive data on complications before the sector in Victoria. And our guidance really stresses the need to interpret these results thoughtfully and carefully. And I probably should say the the report will hit health services on Friday. This is absolutely up to the minute work that I'm reporting on. So yes, so when you finally get to see the data, you will need to look at it carefully, and I think Professor Waters may have a few things to say about this too. We have noted in our guidance in the report that data accuracy, quality and the local clinical governance context should be assessed as part of any response to what is seen in this report. And that's because a comparatively high rate of reported hacks can actually be a result of positive factors as well as an indication of a problematically high level of complications. You really need to use the data as a trigger for investigation to understand what you're seeing in your own health service on the ground. Better clinical recognition, more comprehensive coding. There are all sorts of reasons why you could actually discover that a high rate of hacks in a report actually reflects well on the practice there. At the same time, you may discover that there are things you need to investigate further and perhaps determine how to improve. So we do hope that this report will start many useful conversations in that regard. Next one, please. Thanks, Jess. So, of course, 2020, you can't avoid talking about COVID. And for us, perhaps the opportunity that crisis brought was to develop a really new way of working that I think was very positive and very powerful, directly with clinicians, directly in a really close partnership with Safer Care Victoria, to produce measures, but also visualisations and interpretive material that really answered a deep and pressing clinical need very specifically and in as timely a fashion as I've ever seen managed in government. So I'd particularly call out, because we did report on in-hospital mortality, the work we did for the indirect impacts expert working group, and those measures are just at this moment being implemented in a digital reporting format, a bit like the one Mary sort of showed you some of the COVID reporting for. And we really hope that in the new year, that will be the next layer of innovation available in this space. I will call out too that Vahis also did a similar piece of work with a weekly report around the impacts on the mental health of the Victorian population and mental health and alcohol and other drugs service usage. And that too has had some really powerful consequences in terms of funding for significant investment in services and change in that area going forward. And that again was not just because of the reports we did, but I think because of the really powerful partnership with clinicians in the Office of the Chief Psychiatrist and with the program branch in the department. It's been a great learning year actually to understand how we can make our reports and our work as meaningful and really as actionable as possible. Next slide, please. So 2021 will take those learnings into a work program that some of which is things we'd hope to achieve this year, all of which is very ambitious and all of which involves, I guess, enacting Vahis' strategic plan to up the level of analytics and sort of advanced techniques we utilise in our work, but also to up our engagement and the way in which we explain and provide insight to people rather than just providing numbers and pictures. So once again, I think that means the focus is on the enablers, on how we build skills and partnerships. We're currently in the final selection process of a procurement sort of process that will enable us to enter into a partnership with an appropriate, how shall we say, research-based organisation that will enable us to work in partnership with them to uplift our own capacity, but also to deliver on a really ambitious indicated development program. We've already started a targeted recruitment process of people with the high-level skills in stats and data science that we need We're looking at how to leverage our relationships with universities better and connect better with the research community. So we've already started organising student places, and I think we've just advertised our first PhD studentship that will be working in the Health Intelligence Unit. We're also starting work with the sector. It's been the very first steps quite recently, but starting to talk to key stakeholders in both the public and private hospital sectors about the opportunities for more transparent benchmarking, particularly around quality and safety, for the sake of the safety of patients in whatever setting. There's a lot of work to do there, but we've started it. What that will mean for our mortality reporting in particular, one of the rather long overdue recommendations of targeting zero is that we ought to be displaying our mortality indicators in a way that is going to let people see where the problems start emerging. When you get to the point that that death was the death that tips you into the we weren't expecting that many statistically point. And that means VLADs were what was specifically recommended by targeting zero because they're the particular type of chart used in Queensland, but we'll actually be embarking on a big piece of work to make sure that we are implementing the most up-to-date and appropriate methodology for representing mortality data in that way. We'll be going on with our HSMR project to determine the future of how we'll do a high-level indicator for mortality that still gives people a sort of overview, something that would be useful for boards and CEOs in particular, but that doesn't have the sort of limitations that the sector's been suffering from with the current one, where once you've got that overview, where do you go with it? It's an enormous amount of work to drill down into, but what's actually driving my result, and does it in fact represent a problem? We'll be finalising the development of a new mortality measure, and this is one of the where to with mortality. New measures that give us a broader coverage of the high risk areas, I think, is really important. This emergency laparotomy measure that is on our agenda to finalise and get into our reporting products was developed by the VPCC in liaison with analysts at Safer Care Victoria. So we're picking that up. We'll be doing a validation and report development process, and we hope to be publishing that by the middle of the year. Similarly, we'll be updating the risk adjustment models for all of our mortality indicators using Victorian linked data, and looking to make sure that they can report 30-day mortality outside the hospital walls if necessary, as instead of just the inpatient mortality we're able to report at the moment. And finally, though, we have not yet quite returned to whatever our COVID normal setting will be, but we do look forward to working with the VPCC and SCV in the coming year, and I would expect that that will involve working with them on what would a perioperative indicator work program actually look like and how could we achieve that. So nothing specific there to report at the moment, but I think a lot of goodwill and looking forward to that work. And finally, just to call out that readmission indicators are safety and quality indicators too. We'll also be applying risk adjustment to all of those. The intention is to deliver all of that by June next year. So we'll be making up for lost time. Next slide, please, Jess. And this is the last one. So what comes next? Where are we going to? Well, I think it's already been made clear in a couple of our presentations that digital reporting really does bring new possibilities for communicating better with people, for giving people more options about how they see the data. And I would hope with the benefits of automation to sort of productivity around reporting techniques, I would hope it would free us up to actually do more of that measured development work with the sector as well. We expect to continue working with SCV and clinicians, building closer collaborations based on the learnings from the COVID period this year, and to continue to sort of find ways to strengthen that communication and actionability between problem, data, action. We do envisage on the technical level that we'll be using linked data a lot more. And that's because in the Victorian Health Services data context, linked data means patient-centred data. While it's managed in a way that means we never actually see individuals in an identifiable way, what it does let us do is statistically identify when unique individuals form cohorts. And we can see that rather than just that many hospital separations were had. So we'll be looking at how to build more of a patient-centred perspective as we go forward, I'm sure, as that data enables us to do so. I'm particularly looking forward to the work Paula's got on with linked quality registry data. We will be doing more guidance, and hopefully Chris will be doing more videos to his parents' delight to support interpretation of the material we put out there. And as I flagged, we'll be working with the government and the sector on increased data transparency. We've got some real ambitions around public reporting in particular there too. So that is it from me.